Welcome everybody to this webinar. My name is Maria del Mar Saez and I'm a product manager at Cytognos. Today I'm very happy to present our invited speaker, Mantas Radzevičius, who is going to present the webinar entitled Experience with Multiple Myeloma MRD in our Clinical Laboratory, Theory and Practice. Mantas is a laboratory medicine physician in the Hematology and General Cytology Laboratory at Vilnius University Hospital Santaros Klinikos in Vilnius, Lithuania. His PhD project is focused on the interaction between tumor cells and their immune microenvironment, as well as expression of immune checkpoint molecules. He performs flow cytometry assays in patients with hematological conditions including leukemia, lymphoma, multiple myeloma, paroxysmal nocturnal hemoglobinuria, and myelodysplastic syndromes. Mantas cooperates with international organizations such as the European Society for Clinical Cell Analysis and the Nordic Organization for Pediatric Hematology and Oncology. We are so excited to have you here today, Mantas, so thank you very much and welcome.
So thank you for the introduction. My name is Mantas Radzevičius, and I'll talk about our lab's experience with performing next-generation flow multiple myeloma MRD. So our lab is part of Vilnius University Hospital, and it's the largest hospital in Vilnius and one of the largest in the country. And we have a pretty large hematology department, and in turn there are enough patients with hematological conditions to warrant flow analysis, which is why they use our department. So our division is part of the hematology lab, and we perform a variety of flow assays for various conditions such as ALL, AML, CLPD, multiple myeloma, as I'll talk about today, as well as myelodysplastic syndrome, PNH, and others. We perform both diagnostics and MRD for many of these conditions, as well as assisting our clinicians who do stem cell transplantations in counting stem cells, as well as our blood bank in doing quality control for the blood products. We also do research in collaboration with international projects such as All Together for ALL, and we try to assist, for example, PhD students doing research by providing flow assays for immune subpopulations, measuring things like oxidative stress, and various others. We also work in teaching interested medical students and laboratory medicine specialists. So what is multiple myeloma? It is a treatable, but currently it's an incurable malignancy of plasma cells, and it is a final stage of a continuum of plasma cell diseases. Some premalignant conditions such as MGUS or smoldering multiple myeloma, which after genetic mutations accumulate, along with things like remodeling of tumor microenvironments and other drivers of clonal evolution, end up with conditions called multiple myeloma, which has a clinical manifestation, which I'll mention later. And of course, while flow is very important in the approach towards multiple myeloma diagnostics and monitoring, it's not the only approach. There are biochemical assays and our imaging tests which are used as well. So for example, the damage done by multiple myeloma towards the bone marrow structure and to the kidneys can be summarized by the acronym CRAB, which includes increased calcium concentration, renal impairment, anemia, and bone structure lesions due to damage to the bone structure. And these can be found doing blood or urine biochemical tests to look for M protein and using immunofixation, and at a higher sensitivity mass spectrometry may be performed. Imaging is also very important because multiple myeloma can have a patchy infiltration of the tissues, and outside the bone marrow, these imaging tests are used in conjunction with bone marrow assays. And of course, in the bone marrow, next generation flow and next generation sequencing for MRD are very important due to their increased sensitivity over older methods such as morphology or immunohistochemistry. So MRD testing is a way to measure the likely remaining amount of malignant cells in the bone marrow after some kind of therapy or intervention. In the case of multiple myeloma, plasma cells remain in the bone marrow due to various adhesion and migration factors. However, there are exceptions, such as plasma cell leukemia or extramedullary disease, as well as things like solitary plasmacytomas, which are confined to a specific place. So MRD is based on a statistical theory, and it enables sampling a certain amount of bone marrow aspirate to allow to represent the general situation in the entirety of bone marrow in the body. And of course, the more of the bone marrow is tested, the larger sample you have, the more reliable it is. And a couple of concepts that are used in MRD are the level of detection and level of quantification, which show the lowest amount of events which can be reliably called MRD, or our population of interest, and limit of quantifications shows the lowest calculable amount, which we can express as a percentage of the total. And these concepts depend very much on the amount of cells we are measuring, and can also be dependent on the assay we are using. So, for example, if in multiple myeloma, since the phenotype of myeloma cells is favorable to flow cytometry detection, we can call MRD on smaller amounts of cells than maybe for some other assays. So 30 events is considered in general a good level of detection, lower level of detection, but for myeloma 20 events is a consensus amount which we can already call MRD. And of course for other assays like acute lymphoblastic B leukemia, 10 events may be considered in certain protocols as the level of detection. So why is MRD important in multiple myeloma? Well, MRD is being increasingly suggested and used as an endpoint for treatment, as a surrogate endpoint for overall survival and progression-free survival. And achievement of MRD negativity is being considered due to, for example, changes in International Myeloma Working Group guidelines as a response criteria in addition to classic complete response criteria. And for MRD purposes, next generation flow and next generation sequencing are equivalent in their sensitivity, although there are some advantages and disadvantages to both. But either can be used for MRD if the patient is eligible for that, and of course applicability is a bit higher in next generation flow studies. So it has been shown that MRD negativity improves outcomes despite disease setting, either it's high or standard risk according to genetics, or newly diagnosed or recurrent relapsing multiple myeloma, and the depth of response in all these settings, MRD negativity is shown to be correlated with greater outcomes. And one of the most important parts is not generally a single time point MRD negativity, but continuous MRD, which requires long-term monitoring of these patients who may be MRD negative at one point, but in MRD negativity continuously is a sign of much better outcome. And of course, to achieve these great results, some harmonization is needed. So, for example, the level of sensitivity for MRD to be especially useful has to be enough. So, for example, the level of detection at 10 to the negative 5 is both widely applicable to most patients with multiple myeloma, and it's also a good goal. However, the best would be 10 to the negative 6. However, this level of sensitivity depends very much on the sample and its quality, and not as much on the assay, but it's also very much important as a goal, so that importance should be explained to the clinicians as well. And this is why next generation flow is very much important in the performance of MRD, because it improves on some limitations of older ways of doing MRD, such as sensitivity and reproducibility, as it is based on standardized sample collection guidelines and as well as analysis and reporting. And it can match next generation sequencing by sensitivity, but it is, as I mentioned, more universally applicable. So we have done MRD for multiple myeloma for some time now. However, our previously used panels were lacking in precision. We didn't have markers such as CD27 and CD81, which greatly improve the ability to find these malignant cells. And also, we weren't, for example, comparable. We couldn't compare our results to others in other labs because they may use a different panel than us or different markers, which greatly affects the results. And this also inhibited our ability to participate in some QCs and trials. And one of the primary factors that drove us to start doing next generation flow was the wish of our clinicians, our hematologists, to participate in myeloma trials, where MRD by flow was an important part of them. And the benefits were great, since we increased our sensitivity of assays, and also it introduced us to things like bulk lysis, which we also use for other MRDs now, such as ALL, which we also participate in collaboration with the Altogether group. And another very important part is the use of CE-IVD reagents, which are increasingly being required in Europe for a lot of clinical laboratory assays. So we found the panel suggested by Euroflow for MM MRD very useful. It included many more markers which can be expressed by malignant plasma cells, which increased the ability to find them in small quantities, and as well as reagents like multi-epitope CD38, which is very useful when, for example, a patient is treated with anti-CD38 agents such as daratumumab. And of course, a cytoplasmic tube is also very useful for double-checking normal-ish looking populations. And of course, using a standardized panel allows us to have reproducible results, so we can compare with other labs and also participate in international collaboration with trials. So implementing Euroflow guidelines is made easy by available standard operating procedures, which can be found online and are standardized and apply to IVD kits, for example, which adhere to these requirements. So it's quite easy to join in. And of course, guidelines are provided for each step of the analysis process, such as the pre-analytical phase, where, for example, as I mentioned, the sensitivity depends greatly on the quality of bone marrow. So these specific requirements, which apply to the pre-analytical phase, so they apply to your clinicians, are very important. And the samples have to be, of course, fresh. The volume has to be appropriate, so 2 to 5 milliliters. More is unadvisable due to the possibility of hemodilution, and too low may be not enough to perform appropriate analysis due to lack of cells, which is our denominator and is very important for sensitivity of a test. So first pull aspirates are suggested due to higher volumes being inadvisable, as I said, and too low being not enough for sensitive assays. And of course, the samples should be as fresh as possible, taken within 36 hours due to the increased likelihood of lysis, debris, and other things after that time point. So I have here some examples. For example, if you have a goal of staining 10 million cells per tube, and your bone marrow cell concentration is 5 to the times 10 to the 9th per liter, you have in 1 milliliter 5 million cells. So if you have 2 milliliters, you will have 10 million cells in the entirety of the sample, and likely less after bulk lysis. So as you can see here, If you have only 2 milliliters of bone marrow, that's a concentration which you would like to achieve the 10 million cells overall, the lowest 20 million cells overall because you have 2 tubes. The lowest concentration would be 10 times 10 to the 9th per liter. And of course, if you have a higher volume, such as 5 milliliters, the concentration of cells can only be as low as 4 times 10 to the 9th per liter. So of course, more bone marrow is better, but only if you avoid hemodilution. So of course, first pull and should go to flow cytometry, and the hematologist should be aware of these circumstances and what we can do to improve them. Of course, a very important part of the analysis is the instrument setup, and it's outlined pretty well in the Euroflow SOPs. So it involves setting up the scatter parameters, PMT voltages, using rainbow beads, compensations. But of course, very important is monitoring. So when you finish setting up, you have to continuously monitor the PMTs, for example, using the rainbow beads, running them before you run the experiments to make sure that the setup is appropriate. And it's a bit different for example, we use a Canto 2 and a Lyric. It's a bit different for them, and these are provided both for the Canto 2. And of course the Lyric, which in some ways is a bit easier because you can download both assays and fluorochrome configurations and reagent files for many of the assays used in Euroflow. And we also use, for example, for the B-ALL and T-ALL assays. And it involves using BD CSNT calibration beads, which are tied to the experiments. So the monitoring is also part of your daily QC, which is very useful. So I'll reiterate, sensitivity is very important, and it depends on how many events you acquire per tube. So the guides suggest at least 5 million events per tube, which will mean 10 million in all, bringing you to a sensitivity of 2 to the negative 6. However, the goal, let's say, would be 20 million in all, so 10 million per tube, which would be 1 to the times 10 to the negative 6, which is not always, of course, possible due to the sample quality and percentage concentration of cells in the samples, and it can sometimes depend on the debris you get. So it's sometimes useful to set a living cells gate to see how many actual cells you are acquiring. But of course, sensitivity is very important. Other things are also very important, such as hardware. If you have a good computer, it will greatly improve both your experience with analysis, and also things like disk space can be important because files for MRD can get pretty large. So in our hospital, we have a connection to the institution servers, which also improves safety, because if you keep files in, for example, hard drives or removable hard drives, they can get damaged, lost, or somehow stop working, which thankfully didn't happen for us before we had these connections to the servers. Although the downside would be a slower, if you need to get those files from the servers, it takes a bit longer than through a USB cable, but it's also an improvement. And of course, you need software, and Infinsight is a very good example of software used for MRD, because it allows integration of tubes, which if you integrate tubes, you double pretty much your available cells and you increase your sensitivity. So we also use BD Fags Diva a lot, but as you can see here, and if you've used it, it employs a lot of, for example, using standard gates. If you have an experiment set up, of course you can redraw all of them if you need to, but using those preset gates can be insufficient, as sometimes the cells can be in different places, and only a part, for example, of a CD56 positive population is kappa, while the rest is polyclonal. So finding that subpopulation which is malignant can require you to use standard gates, or using non-standard gates, or using software that allows more flexible analysis. Here is another example where you have a CD56 bright population, which can be seen as separate from the rest of CD56 cells, and it has expression of CD117, as well as only kappa, so it's clonal and aberrant, and it would be easier to find if you were using something that doesn't have set gates, but you used additional gates or non-standard gating to find it. So if you're doing manual analysis without a database, there are a couple of steps. Some of them involve cleaning up the windows, so removing the doublets, which may be found here, or the debris, which is usually in this part of the scatter plots, and then generously gating according to the expected phenotype of both plasma cells and malignant plasma cells, which have characteristic expression of CD38 and CD138, as well as decrease 45, 27, usually expression of 56, but not always, and higher side scatter characteristics, which you see here in the malignant cells. And of course, clonal expression of only one light chain, either kappa or lambda, and of course, classically CD117 expression, usually with absent CD81. So if you're manually gating, sometimes it's a bit too much of a bother to separate out all the cell populations outside the plasma cells, which may be sometimes useful in a sample. However, B cells and B cell precursors should be paid attention to, and they can be found by using some gates such as CD19, CD45, and CD81, which is expressed highly in precursors, and kappa lambda expression for the B cells. However, automated gating does the majority of the work, which also quickens up the analysis in those cases. And of course, you can gate manual as well other populations, such as mast cells, which may be important to show the quality of a sample. As I mentioned, the hemodilution is an important factor in decreasing sensitivity, and mast cell concentration is a good measure of how good the quality of the bone marrow is. So if it's too low, it may imply hemodilution. Of course, there are other populations you can gate, and I'll show you some of that gating when I do the live gating demonstration at the end. Here you can see some NK cells and basophils, T cells, NK cells, and basophils, which are sort of grouped together. Sometimes we point out the CD56 expression. For our trial, we need to measure it, but usually they stay in one group unless there is something of interest and you can look into it further with additional panels. So automated analysis is something that can greatly improve the speed at which you do MRD analysis, and it employs a use of a database against which the events in your sample are checked and assigned to normal populations according to marker expression and scatter characteristics, a combination of factors. So of course, after this is performed, you have to check the assignments to see, for example, if there are any stray multiple myeloma cells that were incorrectly assigned, and for other factors as well. And I'll show some of those steps with a sample that was run through automated analysis at the end when I do the demonstration. So it's always important to keep in mind the basics of flow cytometry, because there are some common mistakes that you may fall into when doing analysis of any kind. And of course, adhering to the standard operating protocols for staining, for example, can decrease the likelihood of these mistakes being made. So this is an example from PNH, where you would have incomplete staining, for example, and you would see a population with seemingly with a decreased expression of a certain marker. And this would be also possible in multiple myeloma, where you have decrease of marker expression as a marker of malignant plasma cells. So you can have these weird subpopulations due to decreased staining, and if you follow the protocols, it's much less likely to happen. And of course, it's always important to keep in mind, for example, air or air bubbles, which is the important use for a time gate. And you can see the acquisition maybe was inconsistent, or there were air bubbles, or there was air collected at the end, which you are likely to see in MRD because you are trying to collect every last drop of the prepared sample. So this is important to, of course, double check. And one thing you can see quite often is these sort of either doublet or non-specific populations, which, for example, express both CD19 and CD56. But the telltale sign of it being not real cells is that the expression follows a diagonal, as can be seen in this light gray population here, which is not specific. And usually these kinds of populations may disappear in a different tube. So that is one way of telling that they're not real, as you can only see them, for example, in one of the two tubes. So this is an example of a malignant plasma cell population. It's a bit larger than you would see at MRD in some cases. However, just to show the classical marker expression of malignant plasma cells, you usually have a reduced CD38 expression, along with sometimes a bit brighter CD138. You tend to have a decreased CD45, along with, for example, a higher side scatter characteristic as compared to regular plasma cells. You often have CD56 positive cells, but it's not always the case. You can have CD56 negative, and you would almost never see CD19 positive, although a subpopulation of the malignant cells may be CD19 positive. However, it's possible some of these can be either doublets or debris of some kind. And you would also see CD27 being dim and CD117 being positive, sometimes brighter, sometimes less bright, sometimes negative, but it's a possible expression. And CD81 would be reduced in malignant plasma cells. And of course, the telltale marker of clonality would be expression of only one of the light chains, in this case kappa. And you should also always pay attention to, for example, these time gates, which show the acquisition of the cells, and you may want to remove some air bubbles or places where maybe the cytometer jammed. And here's another quick example of myeloma population, and you can see a sort of smaller subpopulation at the top, and that's classically what doublets look like. And if we gate them, you can see that they are indeed doublets, which are usually found in this sort of corner of the forward scatter height by area gate, and they can be removed in order to purify the population as much as possible, and I'll show some of that in the live gating. And you can also have some populations which are hard to categorize. They are usually some kind of debris or maybe sometimes a subpopulation. However, if they don't take up too much of the cells, they shouldn't pose a problem. So we have a CD45 brighter, most likely a subpopulation of the plasma cells, since it follows the phenotype of the malignant plasma cells for the most part. However, it has a sort of CD45 expression, which is uncharacteristic but possible on malignant plasma cells. And in some cases, you can have more weird things. So in this case, we have 3 subpopulations of plasma cells, of course, the normal ones, which are CD45 sort of dim. They have CD19, and they are polyclonal, so they're fine. However, you also see a more classical myeloma population, which is CD56 positive and kappa restricted light chain. And you can also see another population, which seems to be CD45 bright, 19 and 56 negative, and lambda restricted. So this could be a second myeloma population, which is possible. However, I'm not completely clear on this case, but what I can say, it's definitely not a normal population, and it's not B cells, since they don't have CD19, so that most likely it is aberrant plasma cells that look a bit weird. So what should be included in the report is, for example, the most important part, which is whether the MRD was measurable or positive or not, the sensitivity level at which it was measured, which is important. For example, if there is a certain goal for sensitivity, maybe some phenotype shifts like loss of CD38, which may be related to therapy. And if, of course, your MRD is below the quantifiable, which is 50 cells, you should note the range at which it should be, so the level of detection and the level of quantification. So it gives a ballpark as to what the MRD is. And if other populations are of interest, you can also note them. Usually normal polyclonal cells are important because the ratio between myeloma cells and normal plasma cells is important as a prognostic factor. Some other populations may also be important, so hematogones may show the quality of bone marrow as well. And they, of course, other like B cells, if they are clonal, they should be definitely noted. And of course, other populations, if they show some kind of aberrancy or increases or decreases according to the normal cell counts you would expect to see, should also be noted. And of course, the quality of bone marrow should definitely be noted, usually using the mast cell percentage, and any other incidental or strange secondary findings, maybe a huge increase in CD117 precursors, may indicate some kind of secondary leukemia or other kind of disease. So now I will go to the live MRD gating demonstration. So what I would like to do now is show you a quick demonstration of how analysis is done if you're using a database. So this is a file that has gone through automated analysis, which assigns events to populations of cells according to certain parameters. And the first thing I like to do is to look through these populations and see if there are any major discrepancies that are obvious, and usually it's pretty fine. And I just quickly check to see if something is out of order. Paying especially attention to things that may be closer to plasma cells in their phenotype, and especially the automatically assigned normal plasma cells. And one thing I noticed here is there are some cells that are CD56 bright, and we'll come back to that. As I've mentioned previously, bright cells with CD56 may be a sign of malignancy. So here I also see some CD56 bright cells, and I'll just temporarily assign them to abnormal cells, and I'll look through the rest of the populations, and I'll come back to that. So the rest of them may be kappa CD56 plus, and we have a counterpart of CD56 plus lambda cells as well. It appears as if some of them have a bit of CD19, but we'll see in context if that's a problem or not. And of course, among this, the first tube cells that do not have kappa and lambda, we also see a CD56 bright population, which is also seems to be CD45 dim, CD38 dim, CD27 dim, and appears to be at least exhibiting some CD117 expression. So I'll assign them to abnormal for now, and the rest would go to normal. The red cells in these window combinations are, of course, the abnormal ones, and the black ones are to be assigned in the program. So for now, let's make them normal, the rest of them, and I'll go through the rest of the plasma population, which is usually the first step. You of course have the normal CD19 plus 56 minus cells, and here the black cells appear fine. They may be a bit dimmer in 138, but they don't appear to be abnormal. And assigning some more lambda cells also seems mostly fine. Maybe 138 is a bit dim, but mostly appear to be plasma cells. And of course, from the first tube without kappa lambda, we see some doublets, which usually appear in a corner here, and as a sort of a higher side scatter population or an and-forward scatter, and they may be assigned to doublets. But they usually don't pose a big problem in analysis. And you have a double negative population as well, which a part of it is kappa, and the rest is lambda. And we have also population from the first tube. This looks like it's 19 positive mostly, so I'll assign it to that. Sometimes those things can get misplaced by automatic analysis, but it's usually not the biggest problem. And the way to do that, if it doesn't offer you the assignment, is of course to select all of them and then press on not the suggested populations, but on one of these at the bottom, such as other CD19 plus, CD56 negative. And usually what's left from the suggested cells are various kinds of either debris or sometimes lymphocytes or other cells that exhibit some characteristics that are close to plasma cells, but usually they're not. And we see some CD81 bright cells, which are either debris or possibly some kind of lymphocyte subpopulation, but it appears to be most likely debris, as there shouldn't be many cells that exhibit this phenotype. So I'll just assign them to debris. And for the rest of them, usually when doing MRD, I tend not to worry too much about populations that are hard to figure out, and if they don't fit, for example, if this has a clear CD56 bright phenotype, the suspect cells, those sort of stray populations shouldn't worry you unless they're very much looking like abnormal plasma cells. So I'll just make them debris in the interest of time. And I tend to look through the B cells afterwards, and these appear to be some CD27 positive B cells, but they're kappa and they look like B cells. So that is normal for a subpopulation of B cells to express CD27. And similarly in lambda we can see the same population. And for mature B cells there is quite a large population, but they look dimmer 81. We have CD19, no plasma cell markers, so pretty confidently mature B cells. And of course precursors may be close to the brightness of plasma cells in some cases, but in this case they appear to be pretty confidently precursors, as in no CD138. CD38 is bright, but not as bright as plasma cells, and we have CD19, and of course CD81 is bright as well, and in the kappa lambda window they don't appear to especially express either kappa or lambda. So this would be precursors. And usually there's some leftover cells that are harder to assign, and these appear to be mostly precursors with maybe some kappa lambda, but in the interest of time, let's say they are precursors. Next I usually look over the debris, just looking for the cells that may coincide with the plasma cells we are looking for, the malignant ones. And in this case it doesn't appear because they are in the debris part of the side scatter by forward scatter window, so likely there are no more malignant cells in the debris, and the rest of them are usually not as important. So I'll just assign them to debris for now. And then I look through the rest of the populations, and sometimes of course CD56 may approach, if you have CD56 positive malignant plasma cells, abnormal plasma cells, they may be approached by NK cells in phenotype, but in this case it is possible that yes, some of them are lower side scatter aberrant plasma cells, but probably just a couple of them I'll assign them to abnormal plasma cells, and the rest I will leave to be NK cells and basophils, which are not separated out in analysis, but well, this could be removed as debris, but it appears as it also could be maybe basophils, but they are a bit too low side scatter and forward scatter for that. In any case, I'll assign the whole population. Eosinophils tend to have unspecific staining, or at least they appear to fluoresce sometimes into different channels, so their phenotype is somewhat unpredictable usually, and they can have subpopulations of CD56 apparently, but it's not real expression of these markers. So in this case there doesn't appear to be many cells that enter the specific malignant phenotype, but for these ones I may assign them because they are, although some of them are too large, so that would probably be doublets or debris or just eosinophils. But in any case, no major cells appear to be, and I'll show at the end, just looking through all the populations and assigning them according to phenotype. Neutrophils are usually very spaced out. They take up a lot of space because it's a large component of, I'll just remove some debris here, large component usually of a bone marrow, and in this case it doesn't look like many of them go into the same places as the malignant cells. Maybe a couple of events that may or may not be assigned. And the rest would be neutrophils. And yes, I tend to go through all the populations with an eye towards more the malignant plasma cells rather than the actual populations, unless it is very important or there is some kind of discrepancy with the populations. Since the goal is definitely to assess MRD, it's important to look for the plasma cells, and the rest of the populations are in most cases important in the being the denominator, so the amount of living cells you are dividing by, not as much in what their particular phenotype is. So it seems some non-specific either doublets or small populations that may be some kind of hindrance, but usually not a big problem. These appear to be doublets at least. And yes, the rest I'll just assign to monocytes. Myeloid precursors may be of interest if there is a large increase of them, which may happen in some specific settings of treatment, or you can have secondary increases or secondary leukemia, but that's pretty rare in most cases. And almost done. Mast cells are of course pretty important. As I mentioned, they are a marker for bone marrow quality, and these appear to be some debris, and the rest may be they are probably parts of, no, they appear to be doublets, since in the singlet view they are larger and they form the sort of CD19 positive subpopulation, so which is not seen in mast cells, of course. And the nucleated red cells are somewhat hard to assign usually because they tend to either be very non-specific. Of course, nucleated red cells are negative for all of these markers. In fact, even CD45 is dim, so it's hard to assign them without by positive expression, so only by negative, and of course by scatter characteristics. So just in the interest of time. So now we have plasma cell populations which appear mostly normal, maybe some doublets here which may be removed to clean them up. You may look over the kappa lambda distribution in these populations, and sort of a safe criterion to take would be around 2 to 1 at most as a difference, but it's somewhere between 1 to 1 and 2 to 1 in favor of kappa in most cases. Here it looks like there's more lambda, but that may be due to the CD19 expression differences, so maybe these are more towards the CD19 positive side. And so, of course, if you removed some lambda and take them here, it improves the counts for both. And of course, these are kappa for the same, but it may not change the goal too much. So you have polyclonal populations. These are around 2 to 1, but they appear to be completely fine in most of it, so maybe with some debris. But what we are most interested in is the abnormal population, so I'll put them up front in contrast to the normal ones. And of course, as you've seen, CD56 is brighter than CD56 plus plasma cells, and as you often see, you have CD38 being dim. CD138 is sometimes brighter on the abnormal cells, and you have dim CD45, dim CD27, and if you look at kappa lambda, you have only kappa expression. So now we have only a couple of cells, and this would be, let's see how many events we have. We have 65 events, which is already above our level of quantification, but it's always good to look for more cells. And what I like to do is just bring up all the cells that you have available, and following the expected marker expression of these cells to gate somewhat widely around them, and to see if there is anything that we missed from all the populations, which is usually faster than just assigning them from every population. So as I'm looking at this seems to be at least most of the bad cells, and you can see they have higher side scatter characteristics, dimmer 45, dimmer 38 than normal plasma cells. They seem to be clustered together, which is always a good sign of a bad population, and they only appear to be having kappa expression and CD117. So I think we can safely assign all of these towards abnormal plasma cells. And from 65 we went 65 events, I think it was. We go up to 86, which is not that much more, but it still makes it a bit more robust. And we can safely say that we have a MRD positive or detectable sample. And if you go into a report, it gives you all the nice statistics and things you may use, such as normal populations and their expected values, the phenotype, and a lot of important information, for example, levels of detection for that sample, and the quality of bone marrow according, for example, to mast cells, which in this case appears to be a bit high. So you can go back and check if you didn't assign, I didn't assign too many cells towards mast cells. So yes, thank you, and that's all.